Well, good afternoon, everybody. You've joined us for the CAF COVID Weekly Roundup. Today is December 18th, 2020. It's 1 o'clock in the afternoon. My name is Jason Belden. I'm the Director of Emergency Preparedness for CAF. And with me today, I've got our favorite folks, Patty Owens, the Director of Regulatory Affairs, and Deanne Walters, the Director of Clinical Affairs for CAF. We're going to go over the one AFL that was updated this week. We'll talk about the surge. We'll have some discussions about surge and planning, what you guys should do, as well as a vaccine update. We'll end on a confusing but a high note. And I'll just say that before we get started, as you plan for the remainder of what's left of 2020, CAF will not be holding this webinar on the 25th or the 31st. So we will not have a webinar until the first week of January. So hopefully you guys are enjoying the holiday season despite the craziness that we find ourselves in. But our hope is that you enjoy this holiday season and have some time to sit and reflect and be thankful for what we do have. So with that being said, let's get started on our program today. Give me a second. And as usual, the speaker's opinions expressed are their own on this webinar. It may not reflect CAF's official position. These webinars are brought to you through a grant-funded program through the California Department of Public Health. I have no financial conflicts, nor do the guest speakers today. The intent of the webinars is to give you a situational report of what's going on in the state with some forecasting of what we can see coming down the pike, as well as some best practices and tools where we've identified those that might be able to help you out. So, all right, let's hop to the first update on AFL 20-48.3. And if the slide looks familiar, it's because I had this slide up last week and they changed the AFL, updated it, and they added some criteria within the intake criteria. Really, it's nuanced stuff. You know, Patty put a great detailed kind of red line version of the AFL so you can see how it contrasts from the previous version. What it really boils down to is these alternate care sites have a very, very limited scope of what they can take from an individual facility or from an acute hospital. So I had meant to include the handout with the intake criteria, but I'm limited to 5 handouts, so they're not listed in the handouts today. But if you have questions or you need to send somebody to either Fairview or Porterville or Sacramento, I have the admissions criteria for that. Just email jbelden@caf.org and I'll send you the admission criteria. There on that web, on the AFL, there's a phone number to call for the intake center. And my suggestion is before you even begin that process, it's called the intake center with the residents that you plan on or you hope to transfer there and go over the clinical considerations for each one of them. My suggestion is maybe even take that list for if you think this is a possibility that you may have to utilize this, have your medical director review the charts for folks that may need to be transferred out to make sure that they meet the intake criteria of the alternate care site. That way you can kind of get an idea beforehand whether these folks will have a spot in the alternate care site. So, and as with everything, we'll talk about this in a second when we talk about surge, but decompression is definitely a last resort with the alternate care sites. Okay, so I want to talk about the surge because most of you are in counties that are stretched thin in terms of the acute care hospital resources around you. We have seen increases in cases in skilled nursing facilities, obviously that kind of tracks along with what we're seeing in the community. The problem is when everybody's impacted like this, especially this severely, the staffing resources, which were already poorly developed beforehand, are really, really stretched thin now. And so what we see is, medical surge sites being set up at acute care hospitals. Those folks will need a place to discharge at some point, and we think that could mean that those folks are going to come to you guys as a possibility, and they may not even be COVID recovering people. They may just be normal folks, but the hospitals are acutely impacted now. And so what that means is, as we try to compete for staffing resources, if we have an outbreak, those resources that we had tapped into before may not be there anymore. I've talked to multiple registries that have no staff. I know the state is planning on bringing in some staff from Australia and from Hawaii. Where those staff are going to be distributed to, or how that's going to be incorporated into the state's, kind of medical reserve corps, or what methodology they're going to use to send these folks out, I don't know that yet. But if we're talking about 50 nurses from other countries to be able to come here, the issue is incredibly bad in the hospitals now. So when we think about that, we've talked to multiple counties that are really at their point where they're not going to be able to take evacuations from a SNF. And so that means we really need to plan out all our options if we have to keep folks in-house, even with a skeleton crew of staff. And we realize the 3.5 and 2.4 has not been waived, and I'll have Patty talk about that in a second, about some of our actions around that and what we're trying to get accomplished. But for you guys, that means that there could be a situation in your counties where you're told by your health department or by the hospitals that you cannot move residents there, even in an emergency. And that's the part that makes everybody really scared, start talking about crisis standards of care and things like that. So in order to avoid those worst case scenarios, we need to take steps, or have planned out steps, to be able to mitigate that. And one of those things that we have really shied away from throughout the pandemic has been sharing staffing resources between each other, simply because the exposure risk is so great. But I want to say, if you're already doing staff testing at twice a week, and those staff are potentially coming from the same communities that are impacted, the risk is very, very similar to both the staff and the residents. And so we've not talked about sharing staff during these resources outside of our own company infrastructure. And so we've done this before in disasters. We have a lot of practice at that during normal disasters, and I want you to think about utilizing those resources during this disaster. If it gets to the point where not only can you not get staff, but you cannot move your residents out, and you have to care for them in place regardless of what your staffing situation is. So if that's the case, we've really got to maximize whatever finite resources are within our individual county. When we talk about, in worst case scenarios, if a facility could not get staffing help, there may be a possibility of taking transfers or transferring out a certain portion of that building to another skilled nursing facility that's also currently in an outbreak. And the reason being is, one, the outbreak facility where you would be transferring your residents to would have some built-in protection. They would have antibody protection for a short period of time after having been positive. And so we would limit the risk to the SNF in which you would be discharging folks to. If you decide to go that route, know that you really have two different ways of doing this. You could do it under a memorandum of understanding or a memorandum of agreement, which is just kind of like handshake agreement or a written agreement that discusses how you're going to reimburse the other party from taking your residence. Now, in that situation, you would not discharge the resident. It would just be a temporary transfer. But given the current pandemic and the waiver of the 3-day stay, you could discharge that person to another skilled facility, skilled nursing facility, and that other facility could admit them. And that is currently what is happening in Los Angeles with their designated COVID receiving facilities. So it is possible that you can do that. It's allowed with the current waiver. So if you absolutely have to, you can do it that way as well. And I want to have, before we talk about decompression, I want to talk about maybe some other strategies to keep folks out of the acute hospital, to prevent them from getting acutely ill where they would need to go to a hospital. Because right now, guys, we're getting to the point where the folks might be better served in our buildings rather than go to an overloaded hospital. And so I wanted Deanne to talk about some of the work and on the monoclonal antibodies and make sure that you guys are utilizing that resource. So Deanne, can you talk for a little bit about the monoclonal antibodies?
Absolutely. We just really want to make sure. I know that we've had Dr. Philip Peters on this weekly webinar for a few weeks in a row, not too far back, talking about, bamlanivimab, however you would like to say it. And so right now we have that distributed to the pharmacies. So CAF works really closely with CDPH and HHS to get them into skilled nursing pharmacies so that we can utilize them. The benefits being that a lot of our residents qualify for the EUA for the use of it if they test positive with symptoms. And it is proven to keep those symptoms mild, which, even if it prevents just 2 or 3 people from having to go to the hospital for treatment because they are now with severe symptoms, with the situation in our hospitals, that would make a world of difference. The challenge, of course, is that it is an IV, and even our facilities right now are challenged with staff in trying to find someone who can run that and who can do regular monitoring over the hour of the administration, and then another hour following administration, just to ensure there is no negative reactions. That, of course, is where our challenge is. But we have taken on bigger challenges, and if it's going to be a better care of our residents, we know what happens when they go to the hospital and they sit in the hallways for 5, 6, 7 hours. The exposure that they have now, not just to the lack of care, but to COVID and the situation of what's happening with this surge, it would be really great for us to do our best to try and treat them in-house and keep them from having to go to that situation. So if you do have residents that are testing positive with symptoms, please reach out to your pharmacies. In the CAF newsletter, I said, please reach out prior to ensure that your pharmacy is receiving allocations of this monoclonal antibody, so that you know ahead of time before you get into that situation if you would have access to it. And we want to make sure that we avail ourselves of this treatment for our residents and for our communities because of the situation that we are in. It has a lot of good benefits, and I know that we have some great skilled staff out there that would be able to administer it and hopefully see the benefits. Anyway, Jason, I'm open to any questions if anyone has any.
Yeah, I'll try to read through the questions. If we get something on monoclonal, I'll jump in.
Absolutely.
And so thanks, Deanne. And so one of the questions, and I see questions on the question and answer thing, is what happens if you can't move? What is this? What is this called? And that would be crisis standards of care. And crisis standards of care really apply when there's a scarce allocation of resources. And in this case, it's mostly staff. We have ventilators. We have medical surge capacity within the existing hospital structure. The problem is we don't have staff to staff for folks that are getting sick. And that's the resource constraint that we currently see ourselves in, and to some extent PPE and some other stuff around that. In June of this year, the previous director of CDPH released a crisis standard of care document. I'm not sure if it's on the CDPH website. If you're interested in looking at it, it's a long, drawn-out document, not specific to skilled nursing, but essentially what it does is it lists a prioritization schedule of how you should be doing decision-making when there's times of scarce allocation of resources, meaning you can't have staff. Who should you be providing care to first? Where should that care be limited to? Things like that. It's real. It's not fun stuff to talk about. It makes folks very uncomfortable without being able to provide all the levels of care that we normally would be able to. So our hope is we don't move to that, but based on our conversations with the hospitals, it could be a coming issue. So, and with that, oh yeah, sorry, go ahead, Patty. Yeah.
Okay. Oh, I wasn't sure where you wanted me to jump in with waivers. Just let me know. I'm sorry. I didn't mean to. Yeah.
Yeah, no, and let me just mention the 2 links on the bottom. So if you're interested in doing an agreement or a memorandum of understanding with a facility within your area, we have templates for that. You can download that, put it on your letterhead. It's good to go. And consequently, if you're a receiving facility, and you need some assistance on what are the things you should look at from a surge side, what questions you should be asking from a facility if they need to evacuate to you, what are the things that you're going to need from them. So as you determine your surge capacity, staffing and PPE resources and things like food and water and medical supplies, all of that stuff needs to be kind of factored in when you do resident movement like this. So if you're interested in what those buckets are that you should be asking, there's lots of tools on that surge capacity. And then I'm going to have Patty talk for a second about the waiver process and kind of what we're asking folks at the state and other counties to help us with. Go ahead, Patty.
Hi, if I could remember to unmute myself, that would be awesome. Okay, so staffing waivers. As we all know, at the beginning of the pandemic, we were issued a blanket staffing waiver. And then June 26, 2020, AFL 20-32.1 came out, which made us have to go back to staffing levels of our 3.5, 2.4. But they allowed for us to submit a 5,000A temporary staffing waiver. CAF did create the template staffing waiver and a consideration of needs document, which would give you some thoughts on how to customize it and make it facility specific. Now, we are still able to submit our temporary 5,000A staffing waivers if you're directly impacted by COVID-19. You need to get those staffing waivers in immediately. You do have to send it to 2 specific places. Don't just send it to your district office. There's also an email where you have to send it out. Also, you have to send it out. I'm looking for that as I'm talking. You have to send it to the QHCQ duty officer, and you'll also have to send it to your district office. Some issues, there's multi-layer issues, which I want to discuss right now. Some district offices, specifically, I believe it was LA, that was returning emails to those facilities that were submitting them stating, we're going to review it. However, at this time, we're not approving any staffing waivers. So I want to let you know that's not true. So make sure that you continue to send in your staffing waivers if you're directly impacted by COVID-19. The biggest thing is to make sure the date that you put as the effective date. So if you're going into an outbreak and you're going into crisis, we realize it's the last thing you're going to be able to remember is to try to submit a COVID directly impacted COVID-19 staffing waiver over to these 2 entities. But when you do even the next day and you think about that, make sure you put the effective date, the date you were directly impacted. So hopefully when they approve it, they'll approve it to that date, effective date, and then you'll have your coverage. What we're doing is we are advocating for our members aggressively on the need, and it's not just for our members, it's just across the board for resident safety and care, and to be able to help during this spike in COVID-19. So it's just to assist surge capacities. It's to assist all the counties and any area that's experienced an outbreak. So what we're doing is we're advocating hard. This is some of our critical talking points. One, we really don't want to move the frail and elderly out of our nursing homes. We all know that that's never good. One, no one knows the care they need better than the people who have been taking care of them. And two, there's all the risks associated with transfer trauma and those sort of things. So it's best served to keep these residents in our facilities. And the other issue is that facilities that are not directly impacted by COVID-19, they also need a waiver. Now, even though CDPH is only issuing waivers for facilities directly impacted, that's not going to help with movement of staff. We need facilities that are not directly impacted by COVID-19 to also have waivers, because they might be able to, as long as they maintain their sufficient staffing levels for the safety of their residents in house, they might be able to send 3 CNAs to their neighbor facility, be able to drop down a little bit below 3.5, 2.4, and still maintain their safety levels, but help that facility over there that's in desperate need for staff. And so that's one of the considerations also that we are we're approaching HHS and CDPH on. The next issue is, as Jason probably spoke to, we're getting a lot of responses that contact your MOAC. Well, MOACs are out of resources, and there's only so many resources in California to go around. And there are no registry staff's being used up by every possible, we're all competing for the same staff. People are offering bonuses from anywhere from $2,000 to $5,000 bonuses, but there's just no one available. There are no National Guard on standby. All healthcare settings are competing for the same exact staff. Plus, on the layer onto that is the staff that the MOAC or the registries might be able to send, or the facility may be able to find and recruit. They may not necessarily be the staff needed to be in compliance with 3.5, 2.4 staffing. A big example of that would be, for example, the MOAC could send us 6 nurses, but we actually need 6 CNA. Now, those nurses are going to be great, or anyone the National Guard comes in, any help is going to be great, but it still leaves the facilities at risk of the regulatory compliance issues of being below 3.5 and 2.4. And technically, we should be shipping residents out if we fall below our 3.5, 2.4, and because we could face our, of course, regulatory and liability issues. Also, we don't want to be transferring residents out because there's no beds in hospitals, and other facilities are also needed to help with the surge, because it's an all hands on deck approach. CDPH is also allowing for the program flex, but there's flaws in that. We realize that that's not going to help with movement of staff. It's not going to be the right type of staff we need to be in compliance, that sort of thing. So we are requesting for them to reissue the blanket waiver that they did at the beginning of the pandemic for these reasons. And the biggest reason is to prevent moving into crisis standard of care. We need flexibility in the staff that we can use on the floor with no specific carve-outs. We don't need specific carve-outs or restrictions, and needs to be one bucket approach, like all the hours go into, like we did prior, into 3.2. If they want minimum staffing levels, as they are issuing within their approvals for the workforce shortage waivers, they're allowing us to staff at 3.2. So 3.2 is considered, the safe staffing levels, and we need to be able to move into a one bucket approach where we can count every staff, and then also not have restrictions on our ID team clinical staff and their roles and their required hours, because for example, the IP role. If the infection preventionists, we're in crisis out on the floor with our staffing, we're in an outbreak. If the DON, DSD, infection prevention nurse go out and help, with the 2-hour rounds, or they go help out with feeding during their normal hours, those hours should be counted also within the bucket of hours, because they're out there providing direct care. But if they did that currently, they'd be risking regulatory compliant issues because they're not meeting their regulatory required positions and hours.
And that's why, well, not only did we make that request from CDPH, but we've asked other counties to advocate from a county side. We feel pretty strongly that this is really our only option to get you guys help and to help with the healthcare system as in general. Patty, do we have do we want people to reach out to us if they're being denied these
Yes,
waivers? So
absolutely.
yeah, if you guys are still being declined any waiver at all, we want to have our pulse on that so that we can continue to push as hard as we can to get
We've been very successful, Jason, with getting those approved, especially directly impacted. But I wanna step it up a notch. I want facilities that aren't even directly impacted, that their neighbor is directly impacted, also submit a 5000A and say we would like to send them some staff and we want to be below. So I think we need to step it up a little bit and continue to submit these and push the reasons we're submitting them. Because we need to be able to have staff flow between buildings.
Whoops, sorry, I went too far on the slides there. But so I want to hop to this other step because Patty's got another update on the consent here in a second, or at least I don't know if it's we've got 100% answer, but I think we've got some good information. So in terms of the vaccine information, if you guys are not aware of this, AHCA, the American Healthcare Association, has created a number of resources that are really, really good. 2 of them which are included in the handouts, the clinic setup and talking points for family members. The link there is for those individual resources, and the top link goes to a webinar that was put on by AHCA. If you want to watch the webinar, you have to sign in to AHCA, but it does not require a membership. It's open to members and non-members, so you can both listen to that. And as well as that link has multiple handouts. I just included 2 of those, but great stuff for you guys to borrow from. And so I wanted to, I sat through a webinar from, well, I've sat through more webinars just like you guys have in the last 2 weeks than I can count. But I stole, well, borrowed, however you want to term it. I gathered information from presentations that both the Los Angeles Department of Public Health did, as well as the California Department of Public Health, to develop these slides. And I'll try to indicate where I got these slides from if it's not evident by the slide. But many of you guys are not in Los Angeles County, and Los Angeles did a webinar on, kind of a description of the medications that were approved, their dosing requirements, their storage requirements, and things like that. And I wanted to give that to you guys, even if you're not planning on storing these medications. There may come a time after these first rounds of clinics are done where you would receive the Moderna vaccine to pick up the remainder of your non-vaccinated staff and residents, and for new hires and new admissions and things like that. We may see a diversion of the Moderna vaccine because of its ability to be stored at facilities to be able. So it's possible. Don't just don't turn away from the Moderna virus our vaccine just because you're not going to get it in this first distribution. I think it's important to understand that you may eventually get this, and that eventuality may come in just 2 or 3 months from now. So it's important to understand both of these different vaccines. So the Pfizer requires 2 doses, 21 days apart. No surprise here, the ultra cold storage is at -80 degrees Celsius, and it can be stored in that for up to 6 months. The important thing here is on the Moderna virus, I keep saying virus, vaccine, can be stored at 4 degrees Celsius, which I think is 36 degrees Fahrenheit or somewhere around there. Anyways, in a refrigerated temperature log refrigerator for up to 28 days. So that's a long period of time that you could potentially take possession of the vaccine and scheduling the dosing around what's convenient for you guys. And that's kind of why Los Angeles went to the Moderna vaccine. All right. I want to talk about briefly some information that I thought was helpful for me, that I hope is helpful for you as you talk to your staff. I'm getting, we've had a number of folks that have started the process. I only know of one building that's done their entire building so far, but we have some initial data that would indicate more folks are willing to take the vaccine than we had really originally thought, which is great news. Especially for folks in acute hospitals or skilled nursing that have seen the impact of this. I think for them it's important. We've seen a number of videos being done, and my expectation is that you will see a lot of videos that talk that really speak to your staff, that are filmed or videoed in the voice of staff or staff members as to their reasoning behind why they're taking it, things like that. Any kind of information you can gather like that will help realize or help put the severity of why we want folks to get vaccinated in our buildings. Some of the real easy data you can give to folks, the Pfizer vaccine and as well as the Moderna vaccines have both been shown to be extraordinarily efficacious, meaning really, really effective at stopping symptomatic disease. Even for those folks in the trial that did contract COVID-19, that were outside of that 94% efficacious range, also had reduced severe symptoms of COVID-19. So not only did it essentially stop symptomatic disease in 94% of people, but the people that did get COVID were also less impacted by the virus. So that's all great news. The great thing is these are 2 vaccines that were developed in parallel, but they were not. They weren't sharing information. I promise you that. So big business for pharmaceuticals. But the interesting thing is both of these use the same technology. They both independently came up to a very, very similar vaccine. The amount of studies that they did were over 70,000 between the 2 studies, the phase 3 studies. And age ranges were quite substantial within the control group. And they represented a diverse group of different folks. So all great news. One of the interesting things I found, and maybe you won't find this interesting, but these types of mRNA vaccines have been thought about for many years. And the information that's usually used to develop a vaccine usually starts with a preclinical development. And in the case of SARS or acute respiratory syndrome, we've had a SARS viruses within the world since 2003. And so in 2003, they actually started on this preclinical development of these vaccines way back then. So for 17 years, they've been doing studies on SARS. Those studies obviously were hugely contributory into the development of these vaccines. So when we talk about how a vaccine could be developed this quickly, a part of that was that 17 years of work that they had done prior to this on SARS before they even started on this vaccine. I want to say that the first phase 1 trial of these vaccines were started before the pandemic was even announced in or declared in the United States. They started on these process in January of this year based on information they were getting from China. And the real truncation of this process is that these phases that they go through in the development are being run in parallel, as well as the manufacturing is done in parallel. And that's the really important part. You know, a pharmaceutical company would not pay billions of dollars to manufacture a vaccine that they did not know was going to get approval unless somebody had given them money up front to do that development. And so, and that's what the federal government did. And that is in large part why we've seen such a quick turnaround for these vaccines. It's not because something was skipped or shortened or overlooked. None of that stuff. The safety data for the EUA is easily accessible, and it appears to be completely consistent between the two different vaccines. And that's why I want to present this, because I think the two are so similar that we can draw a lot of parallels between both the Pfizer and the Moderna vaccine. So it really, this is going to apply to both, regardless of what time you get it. Now, I don't want to go into some of these statistical things. I'm not a physician. I borrowed these slides from a physician. So clearly they have some clinical stuff that I'm not qualified to really talk about. But I will say from a layperson's perspective, all of these things tend to align with something that's, we just kind of got real lucky that it's as efficacious as it is. I feel extraordinarily, I think we're extraordinarily lucky that it's as good as it is. So in terms of the unsolicited adverse events, the events they track during the vaccine, these are the kind of the percentages of who, who had problems with injection site pain, or who developed myalgia, or who had a headache, and what those percentages are for the control group versus the placebo group. And you can see in a lot of these things, they're not hugely different outside of the, these kind of myalgia issues look to be quite a bit different from the control group versus the placebo group. Injection site pain, fatigue, pyrexia, chills, all seem to be, statistically higher in those categories, which is not unexpected. That is kind of what the data they've been telling us, is that expect injection site pain, fatigue, pyrexia, those types of things. The real question is, how will that impact us and our ability to do work? Because we know that the CVS and Walgreens is planning on doing a one day shot, and everybody's getting it on that day. What the doctor in LA Public Health really kind of broke out is, the difference between mild, moderate, and severe symptoms, and when those traditionally occur, and which one of those would be likely to, or how likely it is to see staffing impacts as a result of these systematic kind of issues that we get with this specific vaccine. And it has been much less than they had originally thought. And in the doctor's estimation, I don't want to go into all of this because it's very detailed, but they had basically thought that there would be less than 5%. Now, of course, that's their estimation, but less than 5% would have symptoms severe enough that would cause them to miss a day of work. And the good news is all of those symptoms seem to be lessened with folks in higher age ranges. And those symptoms tend to be worse for younger folks, believe it or not. So if you've got a 22-year-old CNA, they're more likely to have reaction to the vaccine than you would for an 85-year-old. More than likely, at least that's what the data says. So Other AE points, obviously you've heard the talk about the information on anaphylaxis, and I'll talk about that in a second. Dr. Horn from CDPH has a slide that I borrowed that I'll present in a second. But as for the unsolicited serious events, what were the serious events that happened during the vaccine trial? And a serious event could be anything. It could be you were hit by a car while you were getting a vaccine. Well, that would be considered a serious event. It would have nothing to do with the vaccine, but it would be counted as a serious event. So it's important to know that the unsolicited serious events, the rate was 0.3% for the control study and 0.4% for the placebo. And so we actually had worse outcomes in the placebo group than in the control group for that. And then the UK update is any person with a history of significant allergic reaction to a vaccine, medication, or food, such as a previous history of anaphylactoid reaction, should not receive the Pfizer vaccine. All right. So yes, it's been approved, as well as the Moderna vaccine was approved last night. The Western States Scientific Safety Review Work Group, that's the group that Governor Newsom organized with Nevada, Oregon, and Washington. They did their own review and they recommend the use of that. We anticipate that Western States Scientific Safety Work Group will also do the same for the Moderna vaccine. And how it affects us is it encodes a spike protein, and requires 2 doses administered 3 weeks apart. I think we covered that already. All right, so vaccination is starting in California. If you've not heard, I know of one facility yesterday that went through their entire building, and they were, to my knowledge, the first one to have their whole building vaccinated in the state. I didn't get any reports of any adverse reactions. Obviously, we're on day 2 now. We'll touch in with those folks later to see if we can learn anything, but exciting news. It has definitely started. So long-term care facilities can do, we're really talking about 2 separate things. The pharmacy partnership program, which either you're in it or you're not at this point. And in the instance where some local health departments have made the decision to take a part of their allocation outside of the pharmacy partnership program and to support either healthcare workers or support an entire facility. In the case of Mariposa County, it was doing a vaccination for the entire facility. In Santa Clara County, they're having healthcare workers drive to vaccination sites. Los Angeles obviously is going to be sending vaccines to you guys to do yourselves. So there is opportunity in your individual counties. I believe Marin County is doing something similar. If you have an interface where you talk to your folks at public health on the vaccine side, if we're getting delays on the pharmacy partnership program, or you would like to try to advocate for your staff to get vaccinated sooner, the counties have the ability to adjust what they're doing, and they can address those issues with their individual facilities if they want to. As far as the state goes, the states all are fully supporting the pharmacy partnership program. So if you want to work with your health department, you can. There's nothing wrong with that, or work with an affiliated hospital. But that would have to come from your local health department to be able to do that. All right. So the FDA requires a vaccine fact sheet for all recipients. That we have the Pfizer vaccine sheet. That's the one that we included last week. Once we get the Moderna one, we'll post that on our vaccine portion of our website. And Patty, can I have you talk for just a second on what we know about the consent forms with CVS and Walgreens? I know that's been a huge point of concern for folks.
Well, yeah, certainly, Jason. The reason it's such a concern is because the messaging is all over the board on it. And the reason the messaging all over the board on it is because there's confusion, and they're using the language of informed consent intertwined with the language for consent. Now, as we know, informed consent requires a practitioner's involvement, which the physician would have to be involved. And there's only certain situations where we have to have informed consent. Now, as outlined in Title 22. Now, having said that, everyone thinks because you're informing them of the risk benefit that means informed consent. So it's being used really interchangeably. So you have to know the talking points. You have to be able to state, are you saying informed consent that's required under Title 22 with the physician involvement, or are you specifically just meaning consent where we're informing them of the risk and benefit, and anyone can do so. So it is regular consent that's needed. There is no regulation for consent for this. The emergency rules on the vaccination program state that clearly. We are protected under that. There's no consent required. Now, Walgreens and CVS have because of their pharmacy board rules, and then because of their administrating the vaccine rules for them, which they were granted to give orders, to be able to write orders for this, it requires them to have a consent form. So they're doing a consent form. It is not an informed consent form. It's a consent form. You cannot. Now, there's a couple layers on this I really want to talk through quickly so we have time and Jason can finish his, but I feel we need to take the time to work through this real quick. Now, there is the unrepresented residents. Now, because this is just a consent form and not informed consent, you're just going to follow your normal process you would for a consent form. You're going to follow what you normally would do for your residents for any immunization or vaccine. That process would continue. You would document on that form that process that you did and who was present for it. There's some questions like, well, who's going to sign for the consent? Well, you want to, whatever you would chart in the chart, your narrative note would be the same narrative note you're going to put on this form. And most likely you'd have two ID team members signing that the ID team agreed and that they're going to, consented to this, and two people, you'd write that narrative note and you guys would sign off on it. Now, the consent form, Walgreens and CVS consent form, also for ones that do have responsible party. Well, we've received clarification on how we can get that. So we've messaged that out. ACA has received clarification on that. CVS and Walgreens have seen the bigger picture and sniffs now. They understand our process a little bit better, and so now we don't necessarily have to have the ink signature. So follow the same process how you would normally do a phone consent in your facility. Whatever you would be documenting in that chart. Spoke with Mr. Smith, went over the risk benefits, the emergency use risk and benefits form. They agree to the administration of this vaccine, and you would sign that off. Same note you'd put there, you would put on that form. Just be consistent, do the same practices that you would normally do, and you'll be fine. So we just need to make sure that everyone is feeling comfortable with that. If you have questions on that, let us know.
Yeah, and I think am I incorrect in this, Patty? I believe these can be emailed in beforehand. Is that true?
Well, it depends on how you'd have to have a paper trail that you're going to be able to put in the residence chart too, because you want your protection of the facility that you did your due process, and then the Walgreens process. So if you emailing the responsible party and they're giving back email consent, you want the proof that you emailed them the information statement, Jason, EAU or EUA, that you want to make sure that you've sent them that, they understand the risk benefits, that they return back an email, and that it says that they agree, that they've read it, and they understand, and that you'd want that. And then you can, the consent form for Walgreens or CVS, you could probably attach that to it, would be good enough. And you could write a little note and just say, see the attachment, and the nurse would sign that, or whoever was doing that. But whatever process, just do it consistently. The biggest thing under regulatory, as we all know, is getting a good process in place and doing it consistently, and making sure that your policies and your procedures are included, that's what you're going to be doing, and document that process.
Perfect, thank you. So, and just jump into the next thing here. So I know this has been a question. Dr. Horn answered it the other day on the CDPH call. All persons, regardless of prior history of COVID-19 infection, are recommended for the COVID-19 vaccine. And I know there's been some questions about that. Well, gosh, we've got short-term immunity. When do we vaccinate those folks afterwards? And Deanne, are we under the understanding that in terms of if you're symptomatic from your COVID-19 infection, they're not going to get the vaccine, and it would after they resolve their symptoms? Is that correct?
I think that the standard practice is if someone is ill, then we don't typically provide a vaccination, and we do wait until they are in a health condition where they can take it. So I would say that would be our typical response, not unlike with the flu vaccine.
Yeah, perfect. Thank you. And I fully expect this is going to be a moving target. We may see some written, kind of guidance from CDPH as to how to address those, because we've got so many people with prior COVID-19 infections right now.
Well, Jason?
Yeah.
And then the ACA frequently asked document is updated every few days, and in there they discuss that as well. So I want to make sure that, and if you go to our CAF page, those resources are there on our vaccination page that we have created just for the vaccination. So there's a link there for the frequently asked questions, and that is a big question on there is, what do you do for people that are not just having an outbreak for COVID-19 or sick with COVID-19, but they have other acute issues going on, and whether we vaccinate or not. And of course, we follow our same practices.
Well, perfect. And that's so that link I had on one of the previous slides, you guys, that's a link right to that. And a part of those documents from AHCA is that FAQ. So perfect. All right. So in terms of, kind of the precautions, I'm not going to go into this, but there's a link on the bottom where you can download this slide. It talks about who can proceed with vaccination, who requires precautions, and where the contraindications are. Obviously, your medical director should be very familiar with this. All right, we're getting towards the end here. I want to try to get through this so I can get to some of these questions. For facilities who've signed up through either one of the programs, here's a link to their website, their webinars, and their email address for contact if you have questions or problems. I have not run into like an 800 number for either one of them, to call in for questions. So if you guys get those, and you want to share that information, we'll be happy to push it out to folks. But right now, all I know is you've got to send an email in with your question, unless you've been assigned a point of contact at one of these folks, and then you may have somebody who can answer your questions. All right, and I told you about making sure that we have the appropriate resources to be able to counsel our staff and make decisions on what we do in our buildings. And I copied these from Dr. Horn. There are a bunch of information on vaccination for residents of long-term care facilities, information about the pharmacy partnership and post-vaccine considerations, as well as the Pfizer information, and what every clinician should know about vaccine safety and infection control. All right, guys, that was a lot to breeze through. I'm going to try to get to these questions here very quickly. Before I answer questions, I want to make a statement for folks, just to let you know that if you're in Los Angeles County and you have not gone through the sign-up procedure with COVID Ready and Care, We are going to have a webinar next Wednesday at 3 o'clock. So the time that HSAG would normally do their webinars, which they're not having next Wednesday, we will replace that with a 3 o'clock webinar that's going to be for Los Angeles County providers. My suggestion is, if you think at some point you may be shipped the Moderna vaccine, in a couple months from now, these steps and these lessons that Los Angeles County is going to have to learn, it might be a good idea for you guys to at least tune your radar into that in case something happens with the distribution of the Pfizer vaccine, and they need to supplement that with Moderna, whether you're getting stuff shipped, how you work with your long-term care pharmacy, if you're going to involve your long-term care pharmacy and pharmacy consultant. We're going to cover a number of those things on the Los Angeles webinar. So if you're interested, it's not just, you don't have to be from LA just to pay attention. So I put that information out on the forum, and we're going to send it in a magnet mail to every building on Monday, so as well. All right, the rumors are that Los Angeles acute hospitals are limiting resuscitation care. If the patient codes once and stabilizes, they will not resuscitate again. And that would be an example of crisis standards of care. And that's the first step in crisis standards of care. Like I said, most of that information is contained within that really large document that the state produced. If you're interested, if you want, email me. I'm pretty certain that CDPH removed it from any public site, but I do have a copy of it if you're interested in looking at it. All right, so we're in Pasadena, and we received an email from Walgreens. Although a vaccine for COVID-19 has yet to be approved, we anticipate the first product coming soon. Yeah, no, that's, so whoever had that question, something's going on, because folks with Walgreens are already getting their clinics set up. So if you've not received a call from CVS and Walgreens to get your first and second clinics already set up, just know that other providers across the state have already set up their first and second clinics. And so if you haven't been contacted, reach out to one of those two email addresses that I gave you, either for CVS or Walgreens, and try to figure out what's going on. Like I said, they don't have a number to call to verify. And the list I have that I was given, I don't know if it's complete, but if you want a copy of the list of who's signed up for the pharmacy partnership program, email me. It's there's like 10,000 buildings on it in the state. So, but I'm sure if you want to find out if your name's on there, we can do that. All right, are retired vaccinators and workers being asked to return to aid the county and state? And I believe all avenues are being explored, including trying to find previous administrators, CNAs, people that have left the business to bring them back in. To what extent they've explored that, I'm not sure. But at this point, the state's got to consider all they can. I don't know what else, what other methods they're looking for here. We have heard that those who receive the flu vaccine within 14 days should not get the COVID vaccine. Deanne, do you know the answer to that question? Because I don't. To be honest with you, I'd have to ask Dr. Epson if you don't know.
I think I heard that somewhere, but I can't say if that was from a good source or if that was just someone asking another question. I think that at this point, if you know that you have a scheduled date for your vaccine, I would probably, just in case there is a reaction to the flu vaccine, be patient and wait. I think most of our residents are currently vaccinated for the flu, so I don't think that we probably have that many stragglers right now. It would only be new admissions, so I don't think there's going to be a lot of overlap there. But until we get a solid answer, I would wait, so that way we don't have a negative reaction to the flu vaccine and then not be able to provide them the COVID vaccine during your actual date that's scheduled with the pharmacy distribution.
Yeah, and that would be a great question to have your medical director find the answer to that information. Certainly, and I can ask Dr. Epson to have her address it on one of the calls. Well, that's not going to happen for 2 weeks. I'll ask Dr. Epson to see if I can get an answer from you, and I'll copy down your email address and I'll send you the answer once we get it. All right. So when we email CDPH the staffing waiver, what email from CAF can we include or CC for? Yes, definitely. If you get a denial, we want to see that. 100% just forward it on to us. I don't want to get overwhelmed with 1,000, 5,000 A's, so don't CC me on your application.
Yeah, just CC me. You don't see me, don't CC us on the actual application that you submit. What we want is you to forward us any denials. If you're directly impacted by COVID-19 or you're trying to help somebody directly COVID-19 impacted and it was denied and you have compelling stuff in your 5000A that it should have been approved, those are the ones I want you to send us. And I want you to send a clean email that actually states that has the attached program flex and below it has the denial email, that sort of thing. Make sure it's clean, that I can forward it directly over to CDPH to elevate it over to them.
Yeah, no, that's perfect. Thank you, Patty. All right, we're getting towards the end here. There's one last question I wanted to get to. I didn't have a chance to build a slide for this, but somebody had mentioned the vSafe app, and that's a CDC app that is for vaccine safety, and it's to track vaccine safety. Now, I'm not sure if CVS or Walgreens is going to ask you or tell you to have each one of these folks enroll in vSafe, but my suggestion and what LA County is suggesting is that every facility enroll in vSafe. And that's the ability to report adverse events as it relates to the vaccine. I'll need to flesh out whether this would apply even if you're doing the CVS and Walgreens. I assume it is, but I'll find that information out and we'll relay that on the LA County webinar next Wednesday. I'm sorry, that's going to be the last opportunity that I will have to give you guys that information. And the doctor who presented the original webinar that I took the information from, he will be on the webinar, and I'll make sure that he covers the vSafe and how we get started up with that. All right, so I apologize I've not gotten to every question. I know there's a couple more. As I get to them, I will try to email you a response to that. So I want to say thank you guys. Have a great holiday season. CAF Disaster Preparedness will not have this webinar on the 25th or 31st. As a reminder, we will see you first week of January if you're not on the Los Angeles call on Wednesday. So everybody take care. We'll talk to you soon. Stay safe. Thanks. Bye-bye.